Just giving it a few seconds while people are joining. Begin shortly. All right. Hello, everyone, and thanks for joining Data-Backed Strategies to Prevent Surgical Coding Denials. My name is Jordan Leibovitz. I'm part of the marketing team at IMO Health. A few housekeeping items before our panelists begin. This is being recorded. We will send you a recording after the webinar, so be on the lookout in your inbox. If you have any questions while our speakers are speaking, just type them into that Q&A section box on the bottom of your Zoom console. Really take advantage of experts here. It's a good way of getting intel. So today we have a full panel. Dr. Anthony Tedeschi, he is the COO and CMO at MedTel. Matt Menino, he is the Chief Commercial Officer at MedTel. Lisa Woods, she is the VP of Strategy and Transformation at OSS Health. Alex Brown, he is our Product Sales Director here at IMO Health. And last but not least, our moderator for today's session will be Wes Galbo. He is our SVP of Product Manager here at IMO Health. So with all of that being said, I'm going to pass it on over to Wes.
Good afternoon and welcome to our panel discussion. As Jory mentioned, reducing denials and increasing contribution margin for surgical procedures. We have a wide audience today, including perioperative and financial management professionals from health systems of all sizes across the U.S., representing all EHR platforms. We're very excited to bring together these industry leaders today to share actionable insights and real-world strategies. Throughout the webinar, we will introduce a few polling questions. We'll call that to your attention as the discussion unfolds. We'll start first with some brief introductions. I'll invite each one of the panelists to share your name, your role and institution, which to some degree we've covered, but give you also an opportunity to give some perspective on what motivates you to join today's discussion. I'll invite Lisa to go first.
Sure. Hi, Lisa Woods. I'm the Vice President of Strategy and Transformation for OSS Health. We are a physician-owned and operated orthopedic health system in central Pennsylvania. I was actually very intimately involved in the build, design, and implementation of a surgical coordination platform a little over a year ago, and that's really where I was able to take a deep dive into the perioperative revenue cycle, really understand a lot about the various nuances that exist. And at the same time, we actually had a new CEO and CFO join our organization. So we really got to dig into the data and understand where our opportunities lie. And I'd love to share that experience with the rest of the group.
Thank you, Lisa. Dr. Tedeschi, would you like to go next?
Yeah, thanks, Wes. I'm going to say good morning because I'm out in the Denver area. I'm Dr. Tony Tedeschi. I serve as the market CMO and COO for MedTel. By way of background, I've been in healthcare as a provider, as an administrator for over 40 years. I served for a number of years in Tenet Health. I was the CEO for the Detroit Medical Center, a large academic medical center, as well as CEO for the Michigan and the Illinois markets. My experience in periop revenue cycle management, gosh, I've been involved in growth and operations of large surgical service lines in a number of organizations, again, for many years. My motivation for today, it's interesting. As a healthcare operator, I've always been extremely focused on working with institutions on surgical services growth and improving efficiencies, right? That's been a big part of my history. I will tell you that the revenue cycle around those services at times was pretty frustrating for me. I was always working with my financial team to look at how we can improve that and drive contribution margin. Much of the work I've done over the last few years has really been around surgical care coordination. And that has been really meaningful, and we've had some great outcomes and improvements. More recently, I've spent time working on the revenue cycle side, looking at developing and implementing a system that looks at how to help drive financially responsible choices for site of care selections and admit type selections. And again, you'll hear me emphasize I'm always about we start with what's clinically appropriate, but as you'll hear today, we've had some great success there. I would recognize Lisa and OSS Health as being incredible partners in developing, building, and implementing that work. So thank you, Wes, for the opportunity. I look forward to being a part of the discussion.
Thank you very much. I'm glad you're here today. Matt, would you like to go next?
Yeah, of course. Hey, good afternoon. Thank you, Wes. Matt Menino, I'm the Chief Commercial Officer for MedTel. Been in healthcare for 25 plus years on the sales and marketing side, and really that experience is driven around new and innovative solutions and helping bring them to the marketplace. So excited for today's discussion.
Thank you, Matt. And we'll round out with the IMO Health team. Alex?
Thanks, Wes. Hey, folks, my name is Alex Brown. I am the product sales director over our IMO Core Periop and IMO Core Procedure Solutions here at IMO. So, on a day-to-day basis, my role is to work with healthcare organizations, help them identify problems inside of their surgical scheduling space, inside of their perioperative revenue cycle, and see how we can help bridge those gaps and those problems for them using terminology solutions, and really just talking to clients to learn about what are they seeing out there in the healthcare space, what are they seeing out there in the surgical cycle space, and seeing where we could plug things in and help fill some of those gaps. So excited to be part of the conversation today.
Thank you. And I'll go last just by way of introduction. I lead product management for IMO Health's point of care solutions. So we're very pleased to bring the community clinical terminology to help improve everything from diagnosis capture to procedure ordering into surgical scheduling, as Alex mentioned. Thanks for all joining today. We'll shift first. Actually, I'll introduce a polling question. Jory, I'll ask that you present one to the team and to the audience, and we'll give folks an opportunity to give your perspective. You'll see it pop up in the polls and quiz, so feel free to vote as you go. And we'll take these responses into consideration and ideally cater some of our discussion today to your responses. We'll shift now into the meat of the webinar today. To kick things off, we'd like the panel to discuss their perspective on the current state of the perioperative revenue cycle. I'll ask Lisa to share your thoughts first. What makes periop revenue cycle unique or especially challenging to you?
So from my perspective, surgeons and clinicians really have their clinical caps on always, and they should. We shouldn't necessarily expect them to know the many nuances of the insurance world, who reimburses for what and where, or the variation that exists among the payers and sites of care. So there are so many rules and differing payer contract structures. It's very difficult to navigate, and it's even more difficult to get buy-in from your surgeons and your clinical team when they're really primarily concerned, as they should be, about the clinical care of the patient. So while the clinical appropriateness will always take priority, as a physician-owned and operated health system, it is vital that we also stay very in tune to the financial aspects so that we can maintain the financial health of our organization.
Thank you. Very interesting. And Dr. Tedeschi, you've lived in this world for a long period as well. What would your perspective be on the unique challenges of the periop rev cycle?
Yeah, thanks, Wes. It's a great question, and I would echo a lot of Lisa's comments. But I guess what I would add is it starts by being such a complex process, revenue cycle management for surgical services. It involves so many stakeholders. They're often siloed. They're often disconnected. Incredibly, as I talk with colleagues, we still have a significant amount of managing that big process is paper-based. It's phone calls, right? It's not well coordinated. And I also hear and have experienced when it's not coordinated, there's a consequence. And the payer consequences to reimbursements can be pretty extraordinary. So it's important that we get it right. In addition, what I would share with you that I hear from colleagues around the challenges in rev cycle management for surgery, right, is that often given all that disconnectedness, what they find themselves doing is simply adding staff, right, to try to work through these processes. And then again, as I talk with them about that, what I hear is finding experienced staff can be really challenging for rev cycle and surgical management. So many people are looking to better automate the process to drive efficiencies and streamline to get the outcomes that we all want to see that impact our contribution margins, EBITDA, and revenue. Thanks for that question.
Yeah, I'll ask for a level deeper, and I'll invite the entire panel to comment in terms of places where you might see the most frequent breakdown or key pieces of the perioperative revenue cycle that might be challenging. Would you find that be part of scheduling, the documentation aspects, coding, billing, collections, the combination thereof? I'll invite Alex. Maybe you go first, just your thoughts and your experience serving the health system landscape.
Yeah, absolutely. I mean, as I said, I'm talking to health systems every single day across the country. I definitely think you hit on the nail when you said, the combination of all of the above, right? Everyone's talking about the complexity. We're hitting on different points. A lot of what I focus on is in that first piece, in that scheduling piece, and the pre-authorization piece. And we'll focus on how do we take terminology and use that to help make things easier for organizations by tying clinical terms to the appropriate code sets. But that's just, kind of the starting point of where all of these processes begin, right? When that surgeon decides that a patient needs to come back in for surgery, and the first thing they need to be able to do is in the system, hopefully document what surgery are they coming back for? What are the codes that they're expecting to perform? Having a relationship between those two is really critical in order to make sure that that's actually an appropriate for your pre-authorization. And then being able to validate what do I need to actually do before this patient even arrives? But there's just so much more that goes into it as you go through the whole process. You get into the billing cycle. And then we'll see things that we don't even necessarily are aware of until we have these conversations with organizations. Recently, something came across our plate where an organization came to us to let us know that they were really struggling with people not placing proper laterality modifiers on their CPT codes when they're sending those out to be billed, and that they were reworking hundreds of these every single day, taking up, coder FTEs in order to have them go back in and apply those laterality modifiers because they weren't added in the first place. So we're constantly, having those conversations and just seeing where are there areas where this breakdown is occurring.
Thank you for that. One of the themes I've heard the group mention is variability in payer contracts as perhaps one of the biggest pain points. Matt, love your thoughts on what you've seen working with your customer base today.
Yeah, it's interesting. It's, Lisa and her team really brought this to our attention. She started describing as we've talked to more and more health systems. You see these similar challenges, whether it's this physician-owned hospital like where Lisa is, or the large academic medical centers. The more complex the organization, probably the stronger even these challenges become. And they'll have multiple sites of care. So let's say there's several ASCs within a local market. You have your hospital outpatient department, your hospital main OR. And for that same procedure, which is, let's say, conceptually clinically appropriate in any one of those locations, they're going to have multiple reimbursement rates. Variety of that same payer, same plan will pay differently at each of those locations in many instances. So the challenge and what happens to the surgeon schedulers is you can have plan B and plan C, and they're all paying different rates at each of those same locations. So what becomes very challenging for surgeon schedulers is one, they don't have any visibility to these variance in rates. So they have no way to approach it this way. So they tend to just schedule on where the surgeon has his next block of availability. Let's get that case scheduled at that location. And it creates a whole set of challenges. One, it really affects margin loss, right? Because you're not performing that procedure in the optimal site. Again, all are clinically appropriate, but which one's optimal from a financial perspective? And the other challenge that we hear, and often from our, say, larger academic medical centers, is then you start to clog up your main OR. So they want to preserve that capacity for these more complex cases that need to be done in the main OR. And they're finding maybe less acuity cases being scheduled there as tag-ons. So being able to identify, hey, which ones are appropriate to decant to the ASCs? How can we optimize the contribution margin by identifying some of these payer rules across our landscape? And ensuring, yeah, all of these are clinically appropriate, but what is the right optimal financial mix of allocation of these cases? So Those were really the things that surfaced, and in some ways, we can't expect surgeon schedules to keep up with all this, right? In many organizations, you could have dozens and dozens of contracts. Lisa said they're focused on patient care. So they've asked for tools to say, how can we standardize this across our landscape to ensure that we're performing our best within our payer landscape?
Yeah, Lisa, would you like to add anything based on your experience?
Yeah, the only thing I would add, I mean, Matt said it beautifully, is that one of the things that we struggled with at OSS is we have a person or two people who have a lot of this knowledge in their head. So it's very localized. And what we really needed to do was get that knowledge out of someone's head and build it into a tool that could help not just that one human being navigate it, but really support us as we continue to grow, and be able to do this work in a way that we weren't just relying on all of that knowledge that one human being had.
Awesome. Maybe it's worth us diving into one particular pain point a bit more in details, and I'll suggest denials. I know that's something that's top of mind for everybody. Um, Alex and Lisa, I'll ask you two to start first, and maybe Lisa to start first. If you're looking at just the denial slice of your business, what would you see as the top causes for denials, whether it would be things like data error during patient intake, missing complete information, bad codes, site of service mismatches? Is there anything that's popping up in your world that really keeps you particularly awake at night?
I would say one of the things that we have historically struggled with a bit, and this is really more specifically on our spine side, are some of those payer specific requirements, like, for example, conservative treatment. So one payer might say this patient must have had 6 weeks of physical therapy before they're considered a surgical candidate. Um, if they failed conservative treatment or they can't actually make it into conservative treatment because of their injury, then that needs to be documented accordingly. And those notes need, completely spell out for the insurance company, be able to provide the authorization. And that inevitably ends up being denied, turns into a peer-to-peer, turns into extra work for our surgeon, dissatisfaction to our patients. There's a lot of hoops that we have to jump through, and they're rarely in the best interest of the patient. But that is really, and those things vary dramatically from payer to payer and plan to plan. And so that's really what we tend to struggle with at OSS Health.
Thank you. Alex, just I know you deal with customers struggling with denials all the time. What are some of the examples that you've encountered that drive
I mean,
surgical denial?
yeah, absolutely. Clients I'm talking to, it could be all over the place. A lot of what organizations keep coming to me and telling me they're struggling with echoes a lot of what Lisa said. Variation from payer to payer, variation from between Medicare and private payers, Medicaid and private payers, and then a lot of what we will hear from clients is just, Lisa said something really good. She said it was in one person's head. And I hear that constantly from
Mhm.
organizations. They'll say, yeah, we know what CPT code goes with that procedure, or we know we need to get that HCPCS code done, but only one person knows it, or it's on a sticky note that is stuck on somebody's desk, or the Google machine that they have up right next to them as they're trying to look these things up. And so we'll see a lot of organizations just struggle to put things in the system, really struggle to make sure that things are built out. They're investing very heavily inside of their EHRs and making sure that they take that investment and really get the most that they can out of it.
So that's a combination oftentimes of the institutional knowledge being contained in limited places, as well as the underlying data, perhaps the structure itself sometimes having gaps or errors.
Absolutely. Yep.
Yeah. Tony, from your experience, Dr. Tedeschi, anything that draws your mind regarding denials in particular?
They are such a dissatisfier throughout the organization, right? It impacts everyone. And I would just comment on what Lisa said. As a physician, um, it's hard to explain like why you can't get what I've recommended you to get because the payer says no. And it creates all kinds of angst for our patients' families, and managing that better, I think, is so important.
Absolutely. And I think from an IMO Health perspective, we certainly see value in trying to proactively eliminate those denials by making that data and information available at the point of scheduling. Thank you for the collective feedback on denials. I think one of the other themes that this group has been articulating, that variability in payer contract structures oftentimes can impact appropriate reimbursement. Perhaps it's worth us driving down just a bit deeper into that conversation. And before we do that, actually, Jory, I'll invite you to introduce the second poll question, just to
Sure
give the
thing.
audience an opportunity to voice their opinion. But I'd like to just go a level deeper and give the panel an opportunity. We'll start with Matt at this point. Again, you gave us some perspective. Just give me your perspective again on how important it is to determine the most appropriate site of care for those surgical procedures, whether it be inpatient, ambulatory surgery center, HOPD, et cetera. How important is that to get that right?
Yeah, I mean, so again, the assumption guiding all this is each one of these sites are clinically appropriate, right? And so that's the foundation what we're looking. So we're really looking just from a payer perspective and a reimbursement perspective. We've seen many cases where it can be 100% variance. So basically, twice as much at one location versus the other, literally across the street from each other. So as you're thinking from a healthcare provider and operator perspective, both these locations are seemingly appropriate. They're the same in terms of clinical structure. So why would I pick A versus B when I can be reimbursed twice as much at location B, right? And again, and we talk about this in people's heads. That's some coder way downstream, or somebody in the financial team way downstream that has that information, never gets to the scheduler when they're making that decision. And being able to do that across every payer for every site for every procedure would be seemingly impossible, right? So those are some of the challenges that we see. The other one that we haven't really touched on, we talked about it, we're talking about site of care quite a bit. The other one really is admit type. And when you think about it and Lisa talked about it, like the surgeons are so focused on patient care and trying to get, delivering the best care they can. But they're often, there is a real push today to get everybody outpatient that you can get outpatient. So it almost becomes the default of, hey, we're going to schedule this one outpatient. And you look and where total joints maybe were 50% in versus out a few years ago, now they're almost 80, 90% in versus out, or out versus in rather. Many of those patients would qualify and seemingly should be an inpatient admit type. But in fairness, a lot of patients, it's just not worth the prior auth effort. It just takes too much for my team. I think we can do it out. What our flags and triggers are able to do is say, well, which one of these do we really want to invest the time? And you put your clinical rules in place. We can set flags and triggers around clinical as well as the financial to identify those highest value exceptions, where it's going to tell you to those prior auth teams or utilization review, this really is one to pay attention to, right? This is one that's worth getting that prior auth completed on. And those are some of the challenges that we hear, right? It's not just about site of care. How do we manage admin type? The landscape, as I keep saying, is becoming incredibly complex. People are strained for time. They're trying to say, like, I just want to get it approved. How do I get it approved in the easiest way? And being able to identify the ones that are really worth those effort and can identify those high value exceptions for those teams. That's how what we're hearing in terms of requests today, right? It's the admin type in addition to site of care is really driving a lot of the pain points for people.
Absolutely. And I think that's a good transition for us to take the next part of the conversation into some innovation and lessons learned. And I think we can keep the theme right now on site of care. Lisa, I would invite you to give some of your perspective on how you've been addressing some of this payer contract variability. Love your thoughts on, again, the level of pain you had and the types of solutions you put in place to really treat that payer contracting as a source of contribution margin uplift. What's your experience been?
Sure. So I could probably talk for 20 minutes on this, but I'll try to keep it as brief as I can. So we actually have a wide array of options in our area. So internally in our organization, we have an ambulatory surgery center, we have hospital operating rooms, and we also have an orthopedic hospital. So we can kind of pick and choose and really streamline our patients to where they need to be We then partner with some external acute care organizations in our local community where we will see patients who have, multiple comorbidities and may not be appropriate for an orthopedic hospital setting, but more for an acute care hospital setting. So what we really were trying to glean from our surgeons is there somewhere from a site of care perspective that they have to be done? And if it's not, yes, this person has multiple comorbidities and they must be in an acute care setting. It's really no, they can be done a multitude of places. Then you kind of go from the clinical piece of it to okay, so from a financial perspective, where is it most advantageous for us to schedule this patient's surgery? Additionally, when we talk about kind of inpatient versus outpatient, so we through all of this, we worked with MedTel, with both Dr. Tedeschi and Matt on the call, as we implemented their platform SurgiScript, and we were building out that platform really from a surgical care coordination standpoint. We again recognize we've got such a wide variety of reimbursement in our various contracts, particularly for our total joint replacement procedures. So that was variation admit status, site of care, inpatient versus outpatient, that type of thing across all of our payers. So we worked hand in hand with MedTel, and they really brought us this amazing platform called Procedure Site, where we were able to really drill down using the system and these rules that were once in someone's head, put them in this platform to help direct our schedulers, our utilization management nurse, et cetera, to, okay, given what the doctor says is appropriate clinically, what's the next best thing? Where can we get the biggest return? So after engaging Procedure Site and having used it for about a little over 30 weeks, we saw an over $700,000 improvement in our contribution margin, no impact to clinical outcomes. So it really just allowed us to take that financial intelligence piece and overlay it to what's best for that patient clinically. And it considerably improved our profitability in a very short amount of time.
Congratulations on that success story. I'm sure you're very pleased. Matt and Tony, would you like to offer any perspective from the MedTel angle on the success?
Matt, I'll take a shot and then hand off to you if that's okay. First, I just want to acknowledge and recognize Lisa and the team at OSS Health. So often when you attempt to put in new technology and manage change, in my experience, it really takes engaged leadership to make that happen, and they've been incredibly so wonderful to work with. The only thing I would add, Lisa, is since we've done that work with you, we've started looking at a number of other institutions and having an opportunity to see the variability in reimbursement, again, for the same procedure in different admit type or site of care. And we encourage folks to really convert reimbursement into contribution margin. As I think most of us know, if you do a total hip in an ASC or an hospital HOPD, there's probably a different cost structure, right? So it's important to consider your costs when you build an automated system. I have been struck by two things. One is the amount of variability in reimbursements. It's far beyond what I would have imagined. As Matt said, it's not uncommon. Reimbursement can be 50% or 100%. Also, I've been impressed with the fact that it's not just one way, right? One ASC may be reimbursed at two times another ASC for one procedure, and then if you were pick another procedure, it could be the exact opposite. So there isn't a simple way to determine site of care selection and the financial impacts. And then the last comment I would make, which I'll say embarrassedly, I probably had this happening in my shops and didn't know it. It's not uncommon for us to find negative contribution margins occurring in sites of care for these procedures based on a payer contract. And one may be a $3,000 loss. Um, had they moved it to a different ASC, it might have been a $3,000 gain. So having these data and putting them into a system that is automated and drives, if you will, better choices has been it's pretty exciting for a lot of folks. And again, I would echo what Matt said. As a physician, it's always clinical appropriateness first. Matt, I hand it off to you.
Yeah, thanks, Tony. And I'll compliment Lisa and the team one more time because as we think about their innovation, their mindset of dealing with this challenge of the payer contracts and trying to really think through, you have a fixed volume, how do you optimize it? And they really innovated a lot in terms of what they asked for in this solution and turning the complexity of these payer contracts into a strategic advantage for their organization. You can see, if you were to annualize what they've done over the first 30 weeks, it's going to be over 1.2 million in contribution margin improvement just from hips, knees, and shoulders, right? So a subset of procedures, and there's more opportunity as we begin to evaluate their cases. Just to shift a little bit as we start to introduce this to others and what they're telling us, and they think through the rule structure. Particularly as we talk to academics, they'll say things like, well, I'm, on the same campus, I have a cancer center and my ASC, but I don't necessarily want all my, cancer cases to go into the cancer center because some of them actually pay more at the ASC and vice versa. Could we put the rule structure around that? Absolutely. That's what the tool is designed to do. And the other one that we hear quite often, and I talked about it earlier in the academic medical center, is like everybody wants their case done in the main OR. I don't have capacity in my main OR. I have a lot of capacity still in my ASCs. Will this help direct, which are the most appropriate cases to those ASCs? Can we look at things like ASA score? Can we look at things like the payer contract? And yeah, absolutely. Those are all of these types of configurations are how you can leverage the solution within procedure side is your clinical guidelines, your organizational guidelines, whether clinical or financial, to apply that level of standardization across your schedulers to ensure that you're optimizing your reimbursement and contribution margin, your financial performance. As we've said multiple times, still clinical care drives everything, right? All clinically appropriate sites, but what one makes the most sense for the organization deemed to be clinically appropriate. And we're seeing great results from Lisa and really excited in terms of bringing the solution further out to the market, and appreciate the conversation so far today. Thank you.
Thank you very much.
Wes, can I just add
Please,
something real
yes.
quick? Something totally unrelated to payer contracts. What it also helps you do is maximize your OR utilization, which is big clinically. So
Thank you for that. And fantastic stories on the role of procedure site and optimizing reimbursement and OR utilization. We love to hear those stories. From an IMO Health perspective, a lot of what we do from core periop world is to really power a lot of these rule sets that you've mentioned, foundational to any revenue cycle decision or any type of revenue cycle rule set that you might want to put into play. It's always critical to have a standard, clean surgical dictionary with accurate CPT code mappings that can become a foundation for, again, not just improving site of care revenue contribution margin, but also denial reduction. And Alex, I'll invite you just based on your experience to share some of the results we've seen in our customer base associated with standardizing a surgical dictionary.
Yeah, absolutely. So as Wes mentioned, I mean, we really do to feel that having that standardized terminology at the very front end of the surgical scheduling process is a key piece in driving any sort of, perioperative ROI, really helping improve perioperative surgical metrics. And we've seen some really great results by working with organizations to take their entire surgical procedure list, ensure that each term really represents what's happening inside the operating room at the level of specificity at which that procedure is going to be performed. So what we'll see a lot of organizations really struggle with is things like generic terminology, where they have really broad surgical procedures that then they are mapping 5, 10, 20, 30, 40 CPT, HCPCS codes to try to capture everything that they could possibly be doing and performing under that one name. And so a lot of what we'll try to do is break down those terms, make sure you have specific terms that ultimately really represent what is going to happen inside of the operating room. And we've seen that drive definitely financial KPIs, and then it allows us to map very targeted CPT and HCPCS level 2 codes to those terms for use in pre-authorization. So if you are working inside of an EHR, that allows you to have that connection between the clinical term and the code sets, and you can use one to essentially help select the others. We have worked with a site recently that told us they saw about a 25% deduction in their pre-authorization denials because they were getting a lot of those denials due to them having the wrong codes. They were sending in codes that were not necessarily appropriate for that clinical term, and that wasn't really lining up. We've also seen some really great improvements in improving surgical KPIs kind of on the back end. Lisa had mentioned how important OR utilization is. One thing that can really help drive OR utilization, block utilization, room utilization is case duration accuracy, which is essentially a metric of how good is your system doing at predicting how long your surgical cases are going to take. In most EHRs, it's probably doing calculations for you and telling you how long is your surgery actually expected to be. And most organizations are then scheduling off of those calculated times. But when you have a lot of generic terminology, you end up averaging together various surgeries that really shouldn't be put together. And so what you want to do is break those down, make sure you have those specific terms. We worked with organizations that have seen as much as a 21% improvement in their case duration accuracy just by fixing the terminology on the front end and then letting their system still calculate the times the way the system wants to calculate the time. So we're not interfering with that math. We're letting it do its math. We're just making sure that you're feeding it accurate, discrete terms on the front end that truly represent what's happening inside of the operating room. And that really does become key anytime you're trying to connect, really to any sort of downstream system after your EHR as well. You always want to make sure you're feeding it discrete terms that represent what you actually performed. And then actually, Wes, I want to add one more thing before I pause. So the other thing we'd kind of hit on earlier in the conversation was that laterality piece. And I had mentioned that we had an organization who came to us and told us that they were really struggling with making sure that they were properly documenting laterality modifiers on their submitted CPT codes. And they were telling us that they were spending like an entire FTE on having people go back and review those out of work use in order to add the modifiers that were not added in the first place. So we were working with them, and right now where we're at is we basically just put together a value set that helps them identify when do you need to have those laterality modifiers. And then we worked with them to put that in the system so that if a procedure is being performed or being billed that requires a laterality modifier, one of those CPT codes is appearing, they are essentially get a pop-up or a warning saying, hey, you need to add your modifier. You didn't add it in that case. And we've already seen a huge improvement. They already informed us that they saw over 50% deduction in those laterality modifiers popping up in their work use, having to be reworked, and that they've already saved, and this is just hot off the presses. We've only been doing this now for about a month, but they're already seeing about a half an FTE reduction in work on those coders and on that rework.
Great story. Great story. Thank you, Alex. We've come to a point where we're at Q&A. I've got a handful of questions that we'll go through. And just to recap what I believe I've heard from this fantastic panel group, we've heard a number of different use cases to improve perioperative revenue cycle, whether it's related to driving site of care reimbursement, whether it's looking to maximize OR utilization and case duration accuracy. Alex, you just brought up several use cases related to denial reductions, and all underpinned by a clean foundational surgical dictionary. One of the questions that's been posed, if you are a health system and you needed to address these, is there a sequence of events to consider? Where do you start? And I'm curious, I'll invite you, Alex, if you'd like to provide feedback first. If you were a health system, where would you start on that journey? Would you couple things together? How do you begin?
Yeah, I mean, I definitely think you could always couple things together. For me, so much of what occurs is about the underlying data. And so that's where I always say I would start, right? You need to make sure that you have the data inside of your electronic medical record, inside of your health system that allows you to power all of these great type of solutions. And so I always think that's a great place to start. And then once you get that data in shape, once you have your surgical procedure list, it's built out, it's appropriate. You have the appropriate codes all associated with those terms. You have really all that terminology part worked out that allows you to put so many other solutions and great things on top of that that then power everything y'all are doing inside the surgical space and inside the revenue cycle space.
Interesting perspective from others. Lisa, where did you start?
Ah,
Everywhere.
yeah.
Everywhere at the same time. That may be a fair answer.
Yeah, I almost feel like you find one thing and then it leads you down a bunch of different rabbit holes. So I don't know that it's necessarily kind of one thing at a time. It sort of all has to piggyback off of each other.
Fair statement. Okay, thank you. I'll pose the next question, second question. This one's related to site of care payments. How will site neutrality payments affect procedure sites? Matt, would you want to answer this question?
Yeah, and happy to jump in. And I think it's one of the things that people are asking, right? If you think about variance and reimbursement, when we move to a site neutral payment schedule, what's the real value? Well, that's why the focus of contribution margin and the acuity becomes so important, right? Being able to preserve the higher acuity cases for your main OR, reallocating or decanting the lower acuity cases to the ASC, which might be a lower cost setting. All those, using the clinical rules in addition to the financial rules become so important. It's not just about the reimbursement, but it's the cost of care that's also affecting uh, contribution margin, and being able to put that into the tool to help guide the decisions what becomes important.
Thank you very much. And we'll close after those two questions. Thanks everybody for your time today, your wonderful insights based on your experience. And again, thank you for your time.
Great.
Thank
Thank you,
you.
Wes.
Thank you.